We did a trial in AML patients with acute myeloid leukemia. These patients received the standard treatment and placebo. The other ones received the standard daunorubicin Araci plus sorafenib between treatment cycles, but also during maintenance phase over a year. We have not yet seen a trial which showed that the addition of the tyrosine kinase inhibitor did increase and benefited for patients with acute myeloid leukemia. We have had some trials showing activity as single agent, but in these trials we did show beneficial effects in patients aged under 60 years in addition to standard chemotherapy. Patients with de novo AML were included in these trials. They have had to have an age below 60 and above 18, and they should have a performance status ECOG 0 to 2. Elderly patients were included in a trial which is published 2 years ago. The elderly patients above the age of 60 were unable to tolerate the additional toxicity by sorafenib added to induction chemotherapy and chemotherapy. The comorbidities also were in a way counterproductive, that patients have had a higher lethality rate in the beginning of the treatment and overall haven't had any benefit for the patients. The main results of our trial are as follows. Patients receiving sorafenib have a more than 12 months increase in event-free survival rate. That means the median event-free survival without sorafenib were 9 months and 21 months with sorafenib. And looking into patients which came into complete remission, the relapse rate was much lower with sorafenib, and patients receiving sorafenib even have not reached the median relapse rate after 3 years. The relapse-free survival was 60% in the sorafenib arm and only 40% in those patients without sorafenib. Our trial was not powered to see a difference in overall survival. Until today, there's a 7% difference in overall survival, beneficial for the sorafenib arm, but that's not statistically significant. We decided to prolong now the observation period because it was a trend towards a better survival rate in the sorafenib arm, and we are looking for a longer period to see a benefit if it's available. We were looking in our trial also for subgroups of patients which might have benefited from sorafenib, but because the numbers are small in these subgroups, we could not show a statistically significant, but based on in vitro data, we expect that patients with FLT3 mutations will have a benefit with sorafenib, but there are additional subgroups to be analyzed, which genetic background we until today do not know, and might be in the future we can select patients which have even more clear benefit with sorafenib. The side effects are apparent in the sorafenib arm. It's hypertension, which needs additional treatment, but also we have more abdominal toxicities in the patient in the sorafenib arm. Overall, the complication rate leading to serious life-threatening events was not different in both groups, but it's clear only those without comorbidities can tolerate the additional toxicities caused by sorafenib. Because Sorafenib is now getting an old drug. The companies which have it in their portfolio are not so much interested to have it labeled for acute myeloid leukemia. Therefore, despite having this beneficial effects, until now the reimbursement is not clear, and we need strong efforts and also some political push towards having such compounds where the patent is running out to be reimbursed for our patients, because as I said, they have had a lower relapse rate, and that's a great event because you do not need additional treatment, and in addition you do not need to get a transplant after having a relapse of the disease.